evening to I welcome I welcome all on behalf of Shreyas E-Learning Academy in the seventh triad of clinical orthopedics. From today, we will be discussing about the lumbar vertebra. And, I would like to request Deshpande sir to start his session. Thank you, sir.
Thank you very much, Dr. Sankalpa. नमस्ते शारदे देवी वीणा पुस्तकधारिणी विद्यारंभं करिष्यामि प्रसन्ना भव सर्वदा. Hari Om. Welcome all of you in this session of lumbar vertebra. We have come across all the major joints which we have seen in our clinical day-to-day practice. That is ankle, knee joint, hip, wrist, then elbow and shoulder joint. And now we are starting with lumbar vertebrae. It is a very the most common vertebra is lumbar vertebra, which we come across in our day-to-day practice. These are our some workshops. First is related to spine in toto, then neurology, then clinical orthopedics, part 1 and part 2. And then this is rheumatology, then neuromuscular disorders. These are all a day workshop. And then we have started some courses affiliated to Maharashtra University of Health Sciences. One is Panchakarma, second one is Kshara Sutra, and third one is rheumatology. So these are some main workshops which we organized, and there was a great response related to it. In COVID situation, last 2 years, we started with online classes, and we have started clinical orthopedics, a complete series of all the joints, 3 days per joint. And this is the second last joint, that is lumbar vertebrae, and the last one will be cervical spine. So this is just an example of say cervical spine vertebral related disorder. A patient comes to you with say first is pain, then restricted range of motion, that is compromised range of motion, and somewhat stiffness is there. So this is a case of osteoarthritis of say a spine patient. See, many a times when we are taking history related to spine patients, special attention should be paid to mode of onset of the symptoms. That is very important. Then whether they are periodic or constant, whether they are getting worsen or better, and what relieves them or what aggravates them is a very important point related to spine, whether they are getting worsen or whether they are getting better. And that is also very important. Precise location of back pain and its character should be known to the physician, should be precisely determined by the patient. Patient should be asked to what he attributes his symptoms. History of say pain, fall, or say any lifting weight, or these type of things to be asked. Acute exacerbation of pain on coughing or sneezing is indicative of something that is, say, where we call it as organic lesion. So these are some important factors related to history. See, mainly we come across a clinical condition, very common clinical condition, and that is known as sciatic pain. If pain radiates into lower limb, its character and exact distribution must be known to the physician. See, mainly we come across two different types of sciatic pain. If the pain is severe and radiates in a well-defined course, that can be outlined on skin surface, especially if it is accompanied by motor, sensory, or reflex impairment. It suggests mechanical interference with nerve fibers of lumbar or say lumbosacral plexus. And on the other hand, if it is vague, diffuse ache, and the distribution is ill-defined, it is more likely to be referred pain originating in disorder joint or ligament. If it is exact course of nerve related pain which patient tells you in a very particular manner, then it is always say disc intervertebral disc prolapse. If it is vague pain, it must be a referred pain. In case of sciatic pain, that must be understood by a physician, and according to that pinpoint diagnosis, patient should be treated. And these are the diagnoses which are dependent on proper history taking. So that is very important. Mainly in case of say lumbar vertebrae, see, local examination is very important, but the investigations should include abdomen, pelvis, rectal examination, lower limb, and peripheral vascular system. So this is also a very important point related to it. Um, so let us start with a patient who comes to you with, say, osteoarthritis. See, osteoarthritis of, say, thoracic also or lumbar intervertebral joint is found very commonly. Who works very heavy, who does very heavy work, but uh, it may or may not be associated with accompanied symptoms. Many a times there are no symptoms also, but if you go for a radiograph for any other reason, you will immediately come to know that there is lumbar spondylitis or say osteoarthritis. The main point or main reason for this is in case of lumbar vertebrae, previous injury to the spinal joint is the main factor related to osteoarthritis. So maybe previous disease involving the joints, that is say kyphosis or scoliotic changes or intervertebral disc lesion, may be the causes related to osteoarthritis. Say in other cases, degenerative changes are also the one of the cause of say lumbar vertebral disc, lumbar vertebral osteoarthritis. Maybe increasing age or increasing wear and tear is the main reason related to osteoarthritis. Now, the beauty of Ayurveda is like though it is Vata Valley, it is situated in place of say Vatasthana. If it is osteoarthritis related to say cervical spine, it is Vata Valley but associated with Kaphasthan. So the treatment will be different in both degenerative cases. In case of say cervical spine osteoarthritis, one has to go with say um, Ruksha plus Ushna Chikitsa. In case of lumbar osteoarthritis, it is Snigdha plus Ushna Chikitsa. So, though it is osteoarthritis, the treatment will change, the mode of treatment, approach of treatment will change according to Ayurveda. So that is very important. Avasthanarup Chikitsa is the beauty of an Ayurvedic treatment. Changes affect in the central intervertebral joints. You can see this particular X-ray. Changes affect central intervertebral joints and posterior intervertebral joints. So, one or several segments may be affected in this case. There are three pillars related to vertebra, that is anterior, middle, and posterior pillar. These are imaginary pillars. In case of osteoarthritis, anterior and posterior pillars gets affected. Imaginary pillars of body of vertebra. In central joints, which are affected first, there is degeneration with consequent narrowing of intervertebral disc, hypertrophy of bone at joint margins. It leads to formation of osteophytes. Now, in this case, you can see in the posterior intervertebral, see, you can see this, you can see my cursor, and in the posterior intervertebral joints, changes are those of osteoarthritis in these, namely articular cartilage and osteophyte formation, that is spurring at joint margins. These changes in the facet joints are most important from clinical point of view. See, you can see the spurring. This is because of spurring, you get osteophytes. These are osteophytes. These are developed in the margins of vertebrae. You can see this. So, what are the secondary effects of these? Rarely, osteophytes encroach upon intervertebral foramen sufficiently to interfere with function of say what we call as function of that nerve. Thinning of articular cartilage of posterior intervertebral facet joint reduces stability of affected segment and predisposes to one type of spondylolisthesis. So it is very important that one should understand and take charge of Nidan part of diagnosis part with the help of radiology. It is very important. Spinal osteoarthritis can exist in quite marked degree without causing symptoms. But there is often a complaint of aching pain in affected area, which worsens on activity. Pain is often worse first thing in morning, and there may be feeling of stiffness when rising from a sitting position. See, these are very important and simple clinical signs and symptoms which will define the osteoarthritis. From rising up from a chair, if you get pain, it is many a times, it is osteoarthritis. Pain is very worst. First is in the morning, but it is not more than 20 minutes. If it is more than 20 to 30 minutes, stiffness and pain, if it is more than 20 to 30 minutes, then it is rheumatoid arthritis and not osteoarthritis. Feeling of stiffness is there. In lumbar region, there is a tendency to acute exacerbation of pain, usually arising suddenly and lasting a few weeks, which is known as acute lumbago. It starts with, it resembles with, it presents with acute lumbago, in which sudden and lasting pain for a few weeks takes place. That is known as acute lumbago. It is start of, or it is it is denoting that you are having lumbar osteoarthritis. These are possibly explained by strain or momentary subluxation of unstable degenerative joint. So there is interference with a nerve in narrowed intervertebral foramen, which leads to radiating pain in distribution of affected nerve. So this is very important. If you get a patient of sciatic pain also, please evaluate it further, and you may get that the reason of intervertebral disc prolapse may be osteoarthritis also. On examination, the spinal movements are moderately restricted. Mainly, flexion is affected in case of osteoarthritis. No muscle spasm is there. No muscle spasm, but especially flexion is moderately restricted in case of osteoarthritis. If there is interference with lumbar nerve root, straight leg raising on affected side, the straight leg raising test is positive in that case, and it is very restricted movement. So, are there any neurological signs? The answer is no in many cases, but in 5 to 10% of cases, maybe neurological deficit is found in case of osteoarthritis of lumbar vertebrae, sorry. During acute exacerbation of pain, there may be impairment of movements and muscle spasm also. It is there in case of osteoarthritis. Uh, do we get some radiological points related to osteoarthritis? The answer is obviously yes. Um, Intervertebral joints, they show narrowing of intervertebral space and osteophyte formation, that is spurring at joint margins. Later on posterior intervertebral joints, facet joints, they also show some changes. There is narrowing of joint space with sharpening of margins of facets. These changes are seen only in oblique projections. So, what is the how to diagnose this osteoarthritis? It can be distinguished from other causes of back pain and from other causes of radiating nerve pain, that is known as girdle pain or sciatic pain. See, we should remember that say demonstration of osteoarthritic changes in radiograph does not necessarily mean that arthritis is the cause of patient's symptom. For spinal osteoarthritis, uh, many a time this is painless also. Many a time spinal osteoarthritis is painless also. Diagnosis, we have to say, we have to be presumptive. Uh, uh, every time it is not justified. Only other possible causes are excluded. Then only we can see where we can be perfect related to the diagnosis. So, history taking, clinical examination, and radiographs, all the three factors are very important in case of diagnosing osteoarthritis. In mild cases, the first thing is say, if it is thoracic spine related, say osteoarthritis, then if the symptoms are severe, treatment is required, a course of active spinal exercises to strengthen posterior muscles, and that is usually more than sufficient along with some Google Kalpa. So important is exercise in case of osteoarthritis of thoracic spine, say along with some Pathya. In case of lumbar osteoarthritis, say maybe along with say moderate disability, uh, may one has to go for long term vyayam, physiotherapy, which is the exercises mainly say passive mobilization may be helpful in that case. Heavy lifting and similar strains to back should be absolutely avoided. Uh, if pain is from a localized lesion, if it is bad enough to cause serious uh, hardship, then we must think of panchakarma along with oral medication. And if you don't get any result of say panchakarma, physiotherapy, some exercises along with some vatagna chikitsa orally, then also if patient is not getting well, then one has to think of say depometrol type of injections, or say you have to refer the case. So these are some important points related to osteoarthritis of lumbar, mainly of lumbar spine. So what are the pain specifics? If the pain is sharp, dull, shooting, burning, etc. There are two main points related to pain. First is radicular. Why radicular? It is dermatomal distribution. Pain when dysesthesia, that is pain when touch. It is related to peripheral nerve damage. If it is radiating pain, it is non-dermatomal. So, how is the onset of pain is also very important. If it is gradual onset, then it is degenerative disc disease, and that is osteoarthritis. Gradual pain onset. In acute cases, acute disc abnormality is there. That is the main important thing, and there is a radiating pain in the back along with say complete sciatic pain like structure. It is related to disc abnormality, sprain, and compression fractures are three main important diagnosis causes related to acute pain in say lumbar region. How severe pain is, that is to be asked to the patient. Along with that, there are some graphs also or scores also, or there is visual analog score and whatnot. If you have done any thesis or something like that, then you must be knowing all the scientific things regarding it. Frequency. Is pain frequent, that is constant, or is it intermittent? So what is the duration of pain? Exacerbating and alleviating factors. What are the factors related to that? Then at what time do you get pain? Yes, it is mainly related to Vata Pitta Kapha timings also. At what time patient gets pain is very important. According to that, we can conclude with say dosh also. But along with that, there are some serious diagnosis. Main is if the pain is nocturnal, consider malignancy. I have seen these type of cases where the malignancy, site of the malignancy was prostate and there was metastasis at lumbar region level. There was metastasis and patient was getting immediate, in a very short period of time, patient got severe pain and patient comes to us. So, what are the red flags related to lumbar disc syndrome? In case of significant trauma history or in minor in older adults, nocturnal pain in supine position with history of cancer is very important, and according to that, we may have to refer these cases. Bladder or bowel incontinence or dysfunction, that is to be considered as a big red flag. Beware of these two symptoms, bladder or bowel incontinence or dysfunction. It is important. So what are the constitutional symptoms? First is fever with chills, then weight loss, then lymph node enlargement. Fever with chills, weight loss, lymph node enlargement. These are important factors related to lumbar disc syndrome. So, what are the risk factors for, say, spinal infections? Maybe recent infection, immunosuppression are some points, main points related to it. And if there is motor weakness, major motor weakness, patient can't walk, patient can't stand, patient is having, say, foot drop, he can't even perform walking, then it is major motor weakness. So the main point is a pain along with, say, red flags. Another important symptom in case of lumbar disc syndrome is morning stiffness. 10 minutes with or without starting problem is one of the main important morning stiffness related point. If it is just 10 minutes of problem, and there is restriction of flexion along with pain, and while flexion of lumbar vertebrae, if you are getting severe pain, then it is osteoarthritis. If patient gets pain for more than 30 minutes or more than 30 minutes, then it is related to rheumatoid arthritis. 40 minutes plus, it is rheumatoid arthritis. But many a times I have seen that if a patient is having morning stiffness of, say, 30 minutes, then also it is considered to be rheumatoid arthritis patient. 2 hours with body pain. So if a patient is having pain for more than 2 hours, 2 hours or more than 2 hours, then it is confirmed as it is a rheumatoid arthritis patient having, say, immunity related problem. This is immunity related problem. So there are two clinical conditions related to 2 hours of body with body pain. First is amavastha, and second one is sajwaravastha. Amavastha is one of the important points to be considered in case of Ayurvedic treatment. And see, a site of how to select site of kalavadhi, period of amasanchiti, and according to that, patient is to be treated with the help of some drugs, amapachak drug. Many a times there is sajwaravastha. See, remember one thing in these practices: if a patient is having CRP level on higher side, then please include antipyretic medicine in your treatment. That is also very important. If you are having ESR or CRP level at a higher side, then go with Visha Dravya Chikitsa, which are having antipyretic effect like Vatsanab. So Katigraha and Katistambha, these are also two important points. So let us come to the next point. Here, there are two persons who are talking to each other. First is saying, "Hey, Dove." Dove is the name of that orange person. "Hey, Dove, I have burning, stabbing, shooting pain. Is that muscle pain?" "No, feel." Feel is name of this white person, and Dove is a name of this a muscular person. "No, feel. That sounds like nerve pain. So to find relief starts by taking this to your doctor." So if you are having burning, stabbing, shooting pain, that is not muscular pain, that is nerve pain. Dove is right. If you have burning, stabbing, numbness, and tingling sensation, it could be nerve pain. Nerve pain is different from aching, tenderness, stiffness of muscle or joint pain, which is also known as musculoskeletal pain. If a patient comes to you with, say, musculoskeletal pain, don't worry. If a patient comes to you with, say, burning pain, stabbing pain, shooting pain, it is not muscular, it is nerve related pain, nerve oriented pain. Burning, stabbing, shooting, numbness, and tingling sensation. It is nerve related pain for which you have to be very much careful to treat these type of patients. There are nociceptive and neuropathic pains. Type of pain is there. There are two phases of pain. First is acute pain and second one is chronic pain. In case of acute pain, it is sharp, immediate pain. Symptoms of disease are there: super fast nerves related pain directly to thalamus. It is always self-limiting. In case of chronic pain, it is persistent, debilitating pain. It is related to the disease itself. Slower pathway and signals travel back forth in interconnected neurons. Resistant to most medical treatment. So, what are the barriers in pain management? First is inadequate knowledge of pain management. If we are knowing 2, 3, oral medications, that is not enough. We should understand avastha while pain, and according to the avastha, we should treat the patient on vata pitta kapha basis. Inadequate knowledge of pain management. Second one, inadequate assessment of pain, which is very important. So, assessment of pain, how to do that? You must have given car for servicing at your local garage. They ask you about the assessment of their services, and then they guide you accordingly. Inadequate knowledge of analgesics, inadequate knowledge of painkillers, inadequate knowledge of, say, Ayurvedic drugs also. That is also a barrier in pain management. They are concerned about adverse effect of analgesics. Many times, today also a patient came to me. She is having severe rheumatoid arthritis and she was taking some painkillers, Etoshine or something like that. She was taking. First question she asked me, can we stop allopathic medicines? Can we stop all the allopathic medicines, including painkiller and everything? And if you say yes, they are more than happy. Concern about adverse effect of analgesic, fear of pain and addiction and tolerance, fear of masking the diagnosis. And there are myths related to pain management. There are some flow charts from modern science which gives you a complete picture, basic picture of it. Pain assessment scales, visual analog scale, numeric pain intensity scale, simple descriptive pain intensity scale, graphic rating scale, verbal rating scale, pain phases scale, numeric pain intensity and pain distress scales, brief pain inventory. So just go through all these things, just go into details with say Google, and you will come across with all this knowledge, with all this information, and it is going to help you mainly in thesis work. Visual analog scale, no pain to worse pain. numerical rating scale, that is 0, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So according to that, you have to uh, measure the pain. And categorical scale, that is none is 0, mild 1 to 4, moderate 5 to 6, and severe, it is 7 to 10. Immediately, not immediately, but if you can control his pain from 7 to 10 to say 2 to 3, 2 to 4, then also it is a good achievement. You can understand this pain phases scale, brief pain inventory. See, just put an X on area that hurts most. So these are the things which we come across. So these are some diseases or some clinical conditions where you get chronic pain. So now let us come to Gurudrasi. according to the Vedana, type of Vedana, not type of Vedana, intensity of pain. We must categorize or classify these in 3 points. Madhya Vedana, you need to go along with Agni Karma and Basti. If it is Tivra Vedana, then go for Vidya Karma along with Agni Karma and Basti, which is very important. If you go with Agni Karma, if you go with Vidya Karma, immediately your pain gets relieved. Along with Vidya Karma, go for dry cupping also in this type of Gurudrasi. So, disease pain has been scientifically defined as unpleasant emotional and sensory experience associated with actual or potential tissue damage. So let us come to the second point, which is very important in case of Rachana. I have talked to you more about these two things in different joint. If a patient is having tendinitis, then you have to think on Kandara and Sira. And for Kandara and Sira, if you want to treat these Kandara or Sira, then you have to be very much go with say Rakta Dhatu. If it is ligament, it is Med related. Med is Upadhatu of Med is Snayu. Peshi, mouse, that is muscles. Barsa, it is Picha. Shleshmadhara Kala, that is synovial membrane along with fluid. And main Majja, Basa, are related to meniscus. So according to that, if a patient is having only pain and related to that, it is only ligamentum flavum injury, then you have to think of say snayu, medasya upadhatu snayu, and according to that go for snehan, upanaha, agni karma, and bandhan, and so on. If you are having anterior longitudinal ligament and there are anterior longitudinal ligament and posterior longitudinal ligament. Posterior is very strong. Anterior longitudinal ligaments are very poor. So, according to that also, we should be prepared to strengthen these type of muscles. Rheumatoid arthritis is again a very, very big challenge, especially in case of the spinal joints. Rheumatoid arthritis often affects cervical spine. Very less time it affects lumbar spine. Joints of thoracic and lumbar spine may be affected, but clinical manifestations are very uncommon. They consist in aching pain of uh, or diffuse pain with impairment of spinal movements. The limbs will usually reveal typical rheumatoid changes in several joints. So, so radiographs are not that way problematic, but in cases of considerable duration, there is rarefaction of vertebrae with thinning of intervertebral disc space. Maybe there is erosion of articular surfaces and facet joints, and radioisotope scanning shows increased uptake in affected joints. So, in this case also, rheumatoid arthritis is very common in case of lumbar vertebrae. And uh, tomorrow, let us start with some pathological investigation. There are so many pathological investigation plus synovial fluid investigations which we will come across tomorrow. So tomorrow we will be starting at 10 p.m. and we may have to take one more lecture. That is not 3 days, but we may have to take 4 days session, 4 days session for say lumbar vertebra. So thank you all for being with us. And today we will be stopping at this particular thing, but tomorrow we will be talking more on rheumatoid arthritis and other mechanical injuries like say chronic strain or say coccydynia, spondylolisthesis, spondylolysis, sciatic pain, and many more things. There are some congenital anomalies also, but we will not be taking much time for that. I will introduce some and then we will go ahead. There are mechanical derangements like prolapse intervertebral disc, acute lumbago, spondylolysis, spondylolisthesis, spinal canal stenosis. There are deformities like scoliosis, kyphosis, lordosis that we all must be knowing. Arthritis is RA, OA, and ankylosing spondylitis. It is a very peculiar and fantastic disease which we all will come across some or the other day in our clinical practice. So a patient comes to you with all nidan done, with all investigations done. It is not that challenging case. If you are exploring the case and you are able to diagnose the case, that is very important. Anyway, if you have any questions, you can ask me. Otherwise, if you have any questions, please put it on your chat box and then we can discuss on that. Otherwise, if you have any questions, you can ask me tomorrow also and day after tomorrow also. There will be 3 or 4 days session will be there. So one more day will be there.
Hello.
Yes, madam.
Yeah, am I audible, sir?
Yes, madam.
Okay. Thank you for the session, sir. And as described by you, the difference between musculoskeletal pain and muscular pain and nervous pain. Then what should be the difference in the principle of treatment in these both?
Say, day after tomorrow, we will be talking on treatment related to, say, neurological deficit related pain and musculoskeletal pain, neuropathic pain and musculoskeletal pain. But musculoskeletal pain is very easy to treat, and if it is neurological deficit, then it is very difficult to treat. If a patient has lost his senses related to urination or say passing fecus, then these type of cases are very very hard to treat. If we cannot treat it, we have to refer it immediately. And there are so many things related to it, MRI and many other things. What may be the probable diagnosis? According to the diagnosis, there will be the treatment. So we will be talking to the treatment on say the third day.
Okay, sir. And one more doubt is, as told by you, in cervical region we need to do, you told Ruksha and Ushna as Kafasthana and Vata dosha. In the lumbar region, Vata and Vata, Snigdha Ushna. So how will the choice of drugs vary, sir, in that then? I mean, as an example, suppose in Gugulu or in that way.
Yeah, I got your point. If a patient comes to you with cervical spine pain, and if you diagnose it as say osteoarthritis, every time if it is the start of osteoarthritis or if it is nutana avastha, mainly it is kapha or kapha pitta pradhana avastha. Just go for Valuka Pottali Swed, that is Ruksha Swed, in case of say Manya Shud or Manya Stamba, mainly it is Kapha Vrutta. And if it is say lumbar disc related pain, then at the same time, that is the same time, you have to give him Katibasti along with say Snehan or Pichu and then Swedan. So that is the minor difference. If patient comes to you in chronic avastha, if it is in nutana avastha, it is okay. If it is in chronic avastha, then the choice of drugs, the choice of guna or the combination of guna may be different also. I will be showing you a chart of guna on the basis of Langan Gruhaniya Adhyay, Charak Sutrasthan. That I will show you tomorrow only.
Okay, thank you, sir.
Thank you, madam. What's your name, madam? And where are you from? Kalkota Sahithi.
Yes, sir.
Yes. Where are you from, madam?
I'm from Telangana, sir. I'm a practitioner.
Okay. Thank you very much.
Yeah. Thank you, sir.
Thank you. This time it will be 4 days session, not 3 days session. So thank you very much, all of you. Thank you, Shreyas E-Learning Academy, for giving me this opportunity. And tomorrow we will be discussing more on diagnostic point, and then on third day we will be talking on treatment point of view. Thank you all.
Thank you, sir.